So let me introduce myself here real quick. I'm Sam Garg. I'm Vice Chair of Clinical Ophthalmology here and Medical Director at the Gavin Herbert Eye Institute, and thank you all for coming. How many of you here are current patients of the Eye Institute? Great, and the rest of you are not yet. Okay. So why talk about this disease? Well, it's estimated that nearly 30 million American adults report symptoms consistent with dry eye disease in the United States. And if you think about how many people that is, that's huge. I think this is probably an underestimation of what we actually see. Because if you actually delve down a little bit deeper into what symptoms can be related to dry eyes, which we'll talk about in a little bit, there's probably more patients out there that actually have this. And this is an extrapolation based on some epidemiologic studies. So the reality is that there's 30 million plus patients in the United States with dry eye disease. Dry eyes is amongst the most common presenting symptom to the general ophthalmologist's office. These symptoms can include foreign body sensation or pain, visual fluctuations, redness, irritation, stinging, burning, tearing, and a host of other symptoms. As a surgeon, we can't afford to ignore the ocular surface because it has a lot of effects on our ability to deliver on our surgical precision, and that then affects outcomes for our patients. There are certain things that we do as surgeons that make dry eyes worse, and LASIK is one of those things, cataract surgery is one of those things. Luckily, both of these effects can be transient in most patients. And so it's just something to keep in mind when we look at these patients. And dry eye disease used to be sort of the thing that doctors would ignore. You have dry eye disease, here's some drops, don't come back. Now it's one of these things that we really try to embrace because we realize that there's so much of our day-to-day life as ophthalmologists and eye care providers that's really dependent on the ocular surface. A lot of our newer technology IOLs, contact lenses, a good glasses prescription are all dependent on a healthy ocular surface. So if we ignore that, we're really not doing a service to you guys. And there's been a lot of research and development in this area over the past several decades, a lot of which we have now and a lot of which is coming to market. But these allow us to diagnose and follow dry eye disease a little bit better and give us a little bit more science and objectivity to disease management. So if any of you guys are my patients, I've done this thing before. Dry eye is one of these things that it fluctuates. It's like a roller coaster. And our job as practitioners is to make that roller coaster sort of like a kiddie ride. You're still going to have some bumps, but the goal is to try to even it out as much as possible. Dry eyes, there's no cure for dry eyes. And so what we have to do is manage it. So it's really important to understand that because if not, it can become quite frustrating. The face of dry eye disease is also changing. Typically, we used to think of the middle-aged female, the perimenopausal female, as the patient who has dry eyes. Now we know that dry eyes affects the full spectrum of our population. And I think some of that has to do with some of the risk factors we see for dry eye patients. So, modern risk factors, prolonged screen time. Almost everyone has an iPhone or a tablet or some kind of electronic reader that plays a role. Contact lens wear certainly plays a role. Contact lenses are almost ubiquitous amongst college students and high school students. LASIK, like we talked about earlier, can affect this. Medical conditions. There's a whole host of medical conditions that can be affected with dry eye disease. Autoimmune disorders, thyroid disease and diabetes, to name a few. And medications. If you look at basically the package insert of any medication, there's going to be some side effect from that you could probably relate to dry eye disease. But some common culprits include antihistamines, antidepressants, and beta blockers. So what else can cause dry eye disease? Well, we talked about this a little bit. Visual tasking, medications, alcohol. We live in Southern California. This is the desert, play a role. Windy environments. Over the last couple of weeks, we've seen patients coming in with exacerbation of dry eye disease because of the changing weather. And then certainly pollutants. Living in Southern California, we don't have the cleanest air here. Certainly not the worst, but it's not the cleanest either, and that can affect dry eye disease as well. So what are our options for dry eye disease? Have you guys walked into Target and walked down the aisles and seen how many drops there are? That's just the stuff that you can get over the counter. Then you look at all the medications. Then you look at all the therapeutics. This is just it's actually not all inclusive, a list of the different options we have to treat dry eye disease, from tears and ointments to medications, anti-inflammatories, to antibiotics, something called thermal pulsation, which we'll talk about a little bit, autologous serum, surgery, dealing with the eyelids, punctal plugs, cleaning the eyelids, and behavioral modification. So there's a whole host of things that we can do to treat dryness. And the sad part about, or the hard part about dry eye disease and treating it is there's no one magic sort of algorithm. You can't just say, if you do this, then this, and this, it'll work for every patient. You have to individualize your treatment to the patient. So when we look at how we've traditionally treated dry eye disease, we've usually waited for you guys to tell us when there's a problem. And manage dry eyes sort of reactively. And used to always lead with artificial tears and say, here's some artificial tears, try that out. And we used to wait for symptoms and signs to get worse before actually being aggressive with treatment. And the problem with that is we're not identifying the root cause. Okay, and we know that dry eye disease is multifactorial. It's a combination of not having enough tears, inflammation, oil glands in your eyelid not working properly. I like to describe the tear film as like salad dressing. It requires all these different components to be balanced in order to get a healthy tear film. And if you don't have that, your tear film won't work properly. Inflammation plays a big role in dry eye disease. And we've learned more and more about this through many, many studies. But we know that there's an inflammatory component to dry eye disease. And this, if it's left unchecked, will sort of act as a vicious cycle, and inflammation will make more inflammation and will cause worse dryness, and then becomes harder to treat and harder to get under control. And the sort of the traditional approach promotes a lot of confusion and frustration amongst our patients and physicians alike. I mean, it really is, dry eyes can be one of the most frustrating things for patients and physicians alike because of how hard it is sometimes to get a handle on. So we talked about predisposing factors a little bit. Increasing age, being female certainly plays a role. Meibomian gland disease. So as part of your tear film, there's multiple components, but there's three major components. There's an aqueous component, water. There's a mucin component, which is mucus, and there's an oil component. And that oil component comes from glands in your eyelid called the Meibomian gland. So when we tell you guys to do warm compresses, the goal there is to get that oil to move a little more fluidly. So in a lot of patients, that oil is stuck sort of like squeeze butter. And if you don't get it to move, those glands can actually atrophy with time. So the goal is to get that squeeze butter to turn into olive oil. Medications, we talked about some being predisposing factors, history of surgery, wearing contact lenses, and then autoimmune disorders are common etiologic factors for this. Most common symptoms, we talked a little bit about this. Ocular discomfort is one of the most common symptoms of dry eye disease. So burning, sore, gritty, foreign body sensation, pressure feeling, pain. This is usually caused by poor lubrication by the tear film. Fluctuating vision is another very common symptom of dry eye disease, and this has to do with the tear film instability, causing altered optical clarity. And then you can be light sensitive from dry eye disease, and then difficulty reading, doing computer work, watching TV, just sort of normal daily tasks. Dry eye disease can really affect all of these things. So why do we care about it? It's not just because it's annoying. It's because it can have actually bad effects on your ocular surface. So in the top left over here, we see an ulcer from dry eye disease. You can have scarring on your cornea from dry eye disease, which can cause altered vision. And then you can have new blood vessels come into the cornea from dry eye disease because of the inflammation. These are all really end stage type things, but can happen if dry eye disease is left unchecked, and can be really difficult to treat once you get to this point here. Okay, the other reason to treat dryness is the eye works like a camera, and the front window of the eye is called the cornea, and that's really what gets affected by dryness. And that interface of air to cornea is where the majority of focusing happens in the eye. About 2/3 of the focusing power of the eye comes from that interaction where the air film hits the cornea. So if the eye has, this is a little bit of physics here, but if the eye has 60 diopters of power, about 40 of that comes from the cornea and the tear film. So really important when it comes to good vision. And for any of you who have dry eyes, you know that your vision can fluctuate if the tear film is not perfect or if you have a lot of dryness. So when we look at our testing options for dry eye disease, there's sort of the tried and true, which is a Schirmer test, is where we put a little paper strip on the eye and we try to see how many tears you make. There's something called fluorescein dye, which we use routinely, the little orange dye that we use in clinic, and we look for the dry spots on the cornea. There's a green dye called lissamine green that looks at something different. And then we look to see how long the tears stay on the surface, called tear breakup time. More advanced testing that's come out in the last couple of years is looking at osmolality or osmolarity, and that's looking at sort of the balance of the tears, sort of the acidity of the tears, and if it's really out of balance, that can help us determine what kind of dry eye disease you have. Looking at inflammation on the surface of the eye with something called MMP9. We have these little tests in clinic, and I'll show you an example of that a little bit later. But it almost looks like a little pregnancy test. And if there's two lines on it, and one's blue and one's pink, if you have the pink one, it means you have a certain amount of inflammation on the surface, which then can help us decide which way to go with your treatment. And now we have a way to look at the oil glands in the eyelid and how those affect the tear film, looking at the amount of lipid in the tear film, and then also looking at the glands directly with something called Meibomian gland imaging. So all of these are things we have here at the Gavin Herbert Eye Institute that help us decide and treat our patients with dry eye disease. So I find that these last ones are really good for patient education and then to help me really follow the disease. Because if I have someone who's inflammatory positive, which is the MMP9 test, and then we put them on anti-inflammatories and they come back in a few months later and now they're inflammatory negative, well, I know that there's been some change to make them go towards this negative status. Or if there's someone who comes in and they say, gosh, doc, no matter what I'm doing, I'm not able to get the relief, but I find some relief from warm compresses, and we check their Meibomian glands and we see that they're all clogged up, and then we do a treatment for that. That can help drive treatments and treatment algorithms. So we'll go through some of the tests real quick, and this is sort of a look into how I look at your eyes when you come in. Tear breakup time is a really sort of useful way to look at the quality of tears on the surface of the eye. So people say, gosh, doc, I'm tearing all day long. I have tons of tears. That's actually not necessarily a good thing. We're looking for quality tears, not necessarily quantity of tears. And so when we look at tears that are breaking up real quickly, they once you blink, the tear should have a staying time on the surface of the eye of about 10 seconds. Most people don't have that. Their tears break up within just a few seconds. And so by trying to quantify that, we're able to try to determine what's causing that and then try to tailor treatment towards that. We use the fluorescein strip for that, and then this strongly correlates with evaporative dry eye. So if we look at dry eye, there's two big headings. There's aqueous tear deficiency, meaning you don't have enough tears, and there's evaporative dry eyes, means your tears aren't working really well. I'm a big believer that those two are really muddled, and most people have a component of both, but there certainly can be a stronger influence of one over the other. Looking at the Meibomian glands, oftentimes you'll come in and we'll push on the eyelids, and that's not meant to irritate you. That's meant for me to see, how does the oil express from the eyelid. Typically, in a healthy ocular surface, when you blink, you release oil into your tear film. But in many patients, especially patients with dry eye disease, their glands are clogged up and they look like this. And so when you blink, you're not getting a proper amount of oil into your tear film. So, again, back to the salad dressing analogy, you're trying to drop butter into salad dressing, and it's not gonna work. And then you can also get, because of long-term inflammation, you can get skin actually growing over those orifices and blocking them even more. So, MGD, I think is pretty much ubiquitous. We see it everywhere. If you come in, for treatment, at least in my clinic, pretty much everyone's leaving with a handout on how to treat MGD, at least at home, with home remedies, including warm compresses. And what we find is that by treating it early, you can prevent some of the late sequelae. So really, you should be treating it early and often. I'm a big believer of treating dry eye disease proactively rather than reactively. Just sort of gross pictures, trust me, I know, but it's what we see. And really, there's no shortcut to treating this part of dry eye disease. Evaporative dry eye disease, again, very, very common. If you look at a study here, 86% of patients evaluated had evaporative dry eye disease. So 14% had aqueous tear deficient, but almost 86% had meibomian gland dysfunction and aqueous tear deficiency. So it's really a big part of our dry eye disease pathology, and it should not be ignored. So drops are not enough. Looking at more clinical surface staining testing, fluorescein staining sort of highlights like this when you have dry spots on your cornea. The cornea has the highest concentration of nerves in the body. So for any place in the body, it has the most number of nerves per area. Okay, and it's a little small area, but it has the most number of nerves. So that's why when you get dryness, you feel like there's something in your eye, or you feel the burning, or you feel the pain. It's because it's really, really innervated. And those little micro abrasions can be very painful. The other thing we see in dry eye disease is signs, which is what we see, don't always correlate with symptoms. There's some seats over here if you like. You can come along, it's okay. And so when we look at dry eye disease patients, there's a lot of patients who look good and feel good and look bad and feel bad, right? And that's pretty, so that's where signs and symptoms correlate. But then there's a fair number of patients who look great but feel horrible. That's a little different challenge to treat. Then there's the patients who look horrible but feel great. Okay, so as yeah, it's true. And those are the patients who come in who want cataract surgery with the fanciest lens available and say, "Doc, I feel great, let's do it." And when we look at their surface and we look at their measurements, there's something wrong, and that's their ocular surface. Then you sort of have to tell them that, hey, you know what? I know you don't feel bad, but you have to use these artificial tears, you have to use these drops before we can talk about surgery. And so sometimes patients aren't the happiest with that discussion. Schirmer's testing, I'm not a big fan of this test. I just throw it in here for just sort of to be complete. But this allows you to measure tear volume. But it can be quite variable, and even amongst the same patient, it's not the cleanest test in my mind. And then looking at the quality of tests, osmolarity is something that we've had for the last couple years. And what we're able to do here is take a small aliquot of tear film and then measure it to see if the tear is imbalanced, and if the tear osmolarity is over a certain value, which is 308 milliosmoles per liter, or if there's a difference between greater than 8 between the two eyes, that's indicative of dry eye disease. And what that tells you is dry eye disease can be variable, and the tear film is unstable. So this is helpful. We don't get it in everyone, and but it can be helpful in some patients. The test that I think is a little bit more useful is this test here. It's called Inflamadry, and this tests for inflammation on the tear film. And so this is that little pregnancy-looking test where you put it in the eye, and then you let it sit for about 10 minutes. And if you get a pink line, you're not having a girl. It means that you have inflammation, and that inflammation, then we should probably treat with anti-inflammatories. The nice thing about this test is it's sort of semi-quantitative. So the darker the pink line, the more inflammation you have, and as we treat it, we can see that inflammation, that pink line, get lighter and lighter. So in my documentation, I'll sort of put a ballpark grade on that. Say, oh, that looks like a 4+, and it's going down to 3+, or it's getting worse. And I think that's important to follow the inflammation associated with dry eye disease. So now we're going to get to the Meibomian gland part of this. So the Meibomian glands we talked about are in the eyelid. Okay, a healthy Meibomian gland structure looks something like this, where you get these parallel rows of the glands. This is the lower lid, and patients with bad Meibomian gland disease can get dropout. This is actually not that bad, but you can see dropout here and some back here, and then there's some clogging near the ends here, and so this is one of those places where the structure correlates to the function. So if you lose a bunch of glands or they look horrible, you're not going to get a nice tear film, a nice salad dressing, if you will. And that's where we go to drops that sort of have an oil component to them. There are several drops on the market that have an oil component to them that can be useful in patients who have bad Meibomian gland disease. And then if we look at Meibomian gland, we sort of, in our documentation, grade the type of, not only how clogged they are, but the type of oil that's coming out, okay, which is important. And it's important, oh, this is the wrong slide, sorry. What happened? Okay, here we go. Sorry. I think we lost a couple slides here. Sorry about that, give me 1 second here. That's, okay, I'm gonna jump here a little bit. Okay, so the treatment for dry eyes needs to be individualized. Okay, so there's no drop and there's no regimen that I can say, ma'am, for you use this, and sir, you do the same thing, and that'll work for you as well. Right? It just doesn't work that way. Everyone's a little bit different. So you have to individualize to not only the type of dry eye that the patient has, but what else is going on in the patient's life, what they're able to keep up with. Dry eye disease is chronic. There's no quick fix. In fact, there's no cure, and it often involves multiple interventions. So you have to treat the lids, you have to treat the inflammation, you have to treat with aqueous tear replacement, you have to do sometimes some behavioral modifications, and we saw that list in the beginning of the presentation of just there's so many things that we have options with. You do want to treat the symptoms. I think that's really important for patients to buy in, because if we don't treat your symptoms and we say, hey, do this, but you still feel horrible, that becomes really frustrating. So it's really important for us as practitioners to keep that in mind and treat your symptoms. But you guys need to realize that doesn't always correlate with what we're seeing. So, and what you feel doesn't always, sometimes you say, gosh, doc, I feel horrible. When we look at your eyes, it feels great. And that's tough, because, we're telling you to do all this stuff, or you're saying that, gosh, I feel horrible, but I'm telling you your eyes look great. So it can be frustrating. So we'll go through sort of the most common way of going about dry eye disease. And first is with artificial tears, gels, and ointments. There's preserved and non-preserved. I'm really not a big fan of the preserved tears at all. I think they play very little role in real dry eye disease. And the reason for that is the preserved tears tend to have preservatives in them. And if you use those enough, you end up getting an allergy to those preservatives. And then you actually start irritating your eye even more with those. So I recommend the preservative-free tears. There are some formulations now that come, I don't have it with me, do I have it with me? That come multi-dose preservative-free. So it's in a bottle that looks something like this, okay? But it's preservative-free, and it has a special cap on it so that it stays preservative-free, but it's not in those little individual vials that you have to keep tossing. So there's a couple manufacturers that have that now. I think those are useful. They can be fine in just really mild dry eye disease. Probably, maybe you guys back there who are really young could do that. But for the rest of most patients, it's usually not enough. There's multiple formulations. They all are a little bit different. And that's why when you go to Target and you see the whole aisle full of stuff. I mean, if there was one winner, that would be the only one there. but there's not, right? So some people like one brand, some people like another brand. I really recommend just going with preservative-free and figure out which brand works best for you. There's some that have oil, there's some that don't have oil, there's some that are made of carboxy methyl cellulose. There's some, there's just so many different formulations, and they keep changing and they keep changing. Nighttime gels and ointments are really useful for patients whose eyes sometimes peek open when they sleep. A lot of people have had surgery of their eyelids and sometimes or have some scarring and their eyes don't close all the way. I think gels and ointments work really well for that. They also help sort of keep the eye moist at night, and a lot of people wake up in the morning with really bad dry eyes. I think this is helpful for those patients. Cyclosporine has been one of our longest standing prescription medications for dry eye disease. It's called Restasis. And you guys have all heard of that? Okay, yeah. Who hasn't heard of Restasis?
How the heck does it work?
Right, good question. The real answer is that the true mechanism in dry eye is not known. But we do know that it's an anti-inflammatory, and that inflammation, by driving down the inflammation, we see an increase in tear production. There's some thought that it works on a certain, what's called calcineurin pathway. And by doing that, you're able to decrease the inflammation. But a lot of how we use medications is what we call off-label. So, when you do a clinical trial for anything, especially a medication, you have to have a specified endpoint. You have to say, I'm looking for the medication to do this. And if it does that, you get approved just for that. But then when it goes to market, doctors are able to use it for whatever they feel is necessary for the most part, as long as they sort of educate their patient on what's on label and what's off label. And so a lot of what we use Restasis for is actually off label, but it works really well for dry eye disease to increase tear production. There's more and more studies coming out that say, hey, maybe it helps the Meibomian glands, maybe it helps with refractive outcomes after LASIK. There's lots of other things where people have found it to be useful, but the mechanism is meant to decrease activation of T cells, and T cells are the inflammatory mediator in the body. It's twice a day dosing. BID means twice a day, and we can use it up to 4 times a day in off-label cases. It can burn oftentimes when you put it in the eye, so I recommend putting it in the refrigerator. As of October 2016, now in 2017, we have that. This is that multi-dose preservative-free bottle, so it instead of having all those vials and wasting all those vials, you can have it in this, and it's a little more ergonomic.
Does that require also that you have to take it for a while for it to have an effect?
Yeah, good question. So Restasis generally takes about 2 to 3 months to kick in. And the reason for that is it's trying to shut down T cell activation, but it does not affect activated T cells. Activated T cells have what's called a half-life of 60 to 90 days. So once they're activated, it takes about 60 to 90 days for them to sort of lose activity and die off. So that's why it takes a little while for it to start kicking in. Lifitegrast is the sort of new kid on the block when it comes to prescription anti-inflammatory medications for dry eye disease, otherwise known as Xiidra. And this is a little much for the audience, but I figured I'd throw it up there just so you guys know that there's a lot of R&D going on into dry eye disease, and this works on a different mechanism. So Restasis was a medication that was used for something else, and they found out that it had some utility in the eye. This medication was made specifically for dry eye disease. It was designed for dry eye disease to block this interaction of the T cell with the surface right here at this LFA1, ICAM1 interaction. So when do I use Lifitegrast or Xiidra? I use it in patients who have positive inflammatory markers or in patients with significant signs or symptoms. It's 1 drop twice a day. Important to know with any medication, especially new medications, what to look out for. This one has a fairly high percentage of patients who have some irritation on instillation, a funny taste in the back of your throat after about 5 or 10 minutes, and transient blurred vision. Most of these symptoms go away with time. But the nice thing about this medication is that in clinical trials, it was shown to have efficacy on symptoms as early as 2 weeks, which is, that's really fast for a dry eye product. So a lot of success so far with it. Has it worked in everyone I put it on? No. Do I expect it to, do I expect to learn more about this medication as time goes on? Yes, but it's nice to have another option for patients. The eye, makes tears, and tears drain into your nose. So I like, when I talk to patients about it, I like to say that the eye is like a sink. It makes tears and it drains tears. And you have these little drainage tubes on either side of the nose that allow tears to drain into your nose. Okay, there's a bigger drain on the bottom, there's a little accessory drain up top. One way that we can keep your eyes moist is to put a little stopper in that drainage. And so right here is what's called a punctal plug. There's different versions of this. There's dissolvable ones. There's ones that can stand, sort of like this one, that can fall out sometimes, and if you don't like them, we can pull them out. There's ones that go deeper into the system that just sort of stay there forever. I'm not a big fan of those. Those are called smart plugs. I don't know why they're called smart. You can't get them out. This is probably one of my favorite ones, called snug plugs. It goes in and sort of expands to the lumen, so you don't have as much issue of them falling out. That's one of the problems that we see with traditional punctal plugs, is you put them in and the patients come back in a couple months later and they're gone because they don't retain very well. In more extreme cases, we can actually cauterize that to sort of scar it closed, or put a suture through it to allow it to scar closed. But a useful way to keep your tear volume up. Topical steroids are another option for dry eye disease. We talked about dry eye disease being inflammatory in nature, and this is a good way to sort of quiet the eye down quickly. So patients, when they come in and they're really irritated, we'll put them on steroids for a short burst to really get them to quiet down. And this does a couple things. It allows some of the other medications to work. So if oftentimes we'll put patients on steroids and then transition them to either Xiidra or Restasis, so that you get them feeling better quickly, and then allow the other medications that come in that take a little longer to kick in time to work. The downside of steroids is, the good side of steroids is they work great. They make you feel great. Just like if you're on a steroid orally for some kind of inflammatory condition or whatever it is, you feel great on it. But the downside is it can cause an increase in intraocular pressure, leading to glaucoma. It can precipitate a cataract when used chronically. That's not going to happen if you use it for a short burst. Or it can decrease your immune system, which then can lead to an infection. So you have to be careful when you put patients on steroids, and make them understand that, hey, to sort of know what to look out for, and to follow up when they're supposed to follow up. Oftentimes patients will be put on a steroid and they won't come back because they work so well, and then they'll doctor jump from doctor to doctor and keep getting steroids because it works well. But it's not without risk. We use steroids chronically in certain conditions, for corneal graft rejection, and those patients, we're following them regularly to make sure that there's no development of glaucoma, and if their cataracts are there, we'll manage those appropriately. It's really important to treat Meibomian gland disease, and so when we look at the Meibomian gland disease, there's multiple ways to do it. Obviously, warm compresses and lid massage work really well. I used to prefer having patients use just a warm, a towel, a clean towel, get it hot, put it on the eyes. Over the last year or two, I've transitioned to having patients use the commercially available pads that you can buy. There's one called a Bruder Mask. There's one called Thermalon. There's multiple of them out there, where you put them in the microwave and then you allow that to deliver the heat. That does two things. Number one, we don't waste a bunch of water. Number two, and more importantly, it delivers the heat more focally and for a longer period of time. Because really, when you do these things, you want to deliver heat for 5, 7, 10 minutes if you can, and then do a little bit of expression and then clean the eyelids. When you look at the eyelid structure, the glands that you want to affect are on the back side of the eyelid. So when you put a warm compress on, you're putting it on from the front. So it has to travel all the way through the lid, albeit very short distance, but it still has to go all the way through the lid to really affect those glands. So that's why you need to leave it on there for some time. There are commercial lid washes versus baby shampoo. Baby shampoo works great, but there are a lot of really nice lid washes out there that you're supposed to do after you do the warm compress. They sort of go together. There's another product called IPL, which is using a light therapy. We don't have that here, but that's gaining some popularity for dry eye disease. And then thermal pulsation, which I'll talk about in a little bit here. That's something called LipiFlow that we have here. And what that is it sort of treats the Meibomian gland disease very effectively, but it comes with a but, and that but is it's not covered by insurance. Topical treatments, topical antibiotic steroids. There's something called azithromycin, which had a lot of popularity a few years ago and sort of fallen off a little bit. And then there's been a lot of talk in the sort of eye world about Demodex, which is this mite that you can find on the eyelashes, and cleaning that with tea tree oil or a commercially available scrub that has tea tree oil in it, because that can also then cause inflammation at the lash margin. And then oral antibiotics. So oftentimes we'll put patients on something called doxycycline chronically, not for its antibiotic purpose or antibiotic benefit, but more as an anti-inflammatory. And this is good for patients who have rosacea. So when we look at warm compresses can have limited efficacy. And this is because of the structure of the gland. The gland is here, but the oils that you want to get are on the back side. I'm sorry, the lid is here. The oils are on the back side, and so you can't always get enough heat to the glands. And the other thing is you can't squeeze the glands effectively. You can't get the glands to express effectively. If you push on your eye, it moves out of the way, right? It's supposed to move out of the way. That's the way it protects itself. So there's no way to get this counter pressure on those lids to get them to squeeze out. So we do have this treatment here. LipiFlow is a in-office procedure that not for everyone, doesn't work in everyone, but it does have a chance of cleaning out those oil glands quite effectively. It has this activator that sort of hugs the lid. So if you look at the lid, this part fits against your eye. Your lid sort of slides in here, and it heats from the back side of that, so right up against the glands. And then it has a little compression element in it to help squeeze out the glands in sort of a rhythmic fashion. Clinical testing with this, we find that the glands secrete better oils. Patients are less symptomatic. This is a patient questionnaire, and this is also a patient questionnaire, and on both of those, at 4 weeks, patients are doing better. 4 weeks is not that long. So if you look at them longer than that, they do better. This is a patient who had sort of blocked glands beforehand, and then you can see how that oil is sort of clear here. This is right after the treatment. The oils look a lot better. But I think this is more important, that out to 12 months, we have an improvement in symptoms with this technology in the right patient. I'm one to sort of downplay technologies. I don't think there's any perfect technology out there, but I think that this is useful for a lot of our dry eye patients and a good kickstart in the right direction. Autologous serum is something else we offer here. This is for really advanced dry eyes for the most part. It's basically taking your own blood and getting it spun down into an eye drop. So there's growth factors in your blood and in the serum particularly. So we take out all the cellular components, and you get delivered to you little eye droppers that last about a week, and you use that in place of artificial tears. And this can be used in patients who have really significant dry eye disease and patients with other ocular ailments. Other adjuncts that I think are really useful for dry eye disease, omega-3s. Most of my patients I have on some kind of omega-3. I'm really in favor of something called re-esterified omega-3s. These are not the ones you buy at Costco. These ones, when you look at any kind of fatty acid chain, for those who've ever taken a chemistry class or an organic chemistry class, it has these chains, and really where the action happens on that molecule is at the end unit. And in most commercially prepared omegas, that end unit gets cleaved. And when that end unit gets cleaved, it affects the absorption of the omega. So you could take 2,000 grams of a medication, it really depends on how much actually gets into you that makes it effective, right? So with reesterified omegas, you get much higher absorption of the omega for the same milligram equivalent of the other ones.
What about omega-3 via salmon fish?
So that's great. But oftentimes you can't eat enough salmon and fish to be therapeutic, for patients who have real dry eye disease.
Can you quantify that?
Mm-mm. Depends on how big a piece you eat, how often you're eating it. I mean, if you're getting
6 ounces every day.
it's hard to know I couldn't tell you for sure. I would say that's good, but I couldn't tell you how much. It also depends on, I honestly don't know if there's a difference between the farm fresh or, this, whatever, all that stuff. Yeah, I'm sure it tastes different for sure. I don't know about the omega part of it though. So, and then certainly environmental factors. I tell patients who have really bad dry eye disease when they read to close their eyes every few pages for 10 to 15 seconds. That can be really helpful. Patients who watch a lot of TV to close their eyes during commercials. You've seen the commercial a million times. You don't need to see it 1,000,001 times. There's something called moisture goggles that you can get. Dry eye support groups. There's dry eye support groups in Orange County, and we can get you some information on that if you like. But that can be helpful.
Excuse me, when do you use the moisture goggles?
Everyone's different. Some people have to use them more often. Some people use them just during activities where their blink rate goes down, so reading and watching TV. Some people use them to sleep in. Yeah.
Are they prescribed?
No, you can get them. You can get them without prescription. So I talked a little bit about innovation in dry eye disease. Allergan is launching a new dry eye product, and it's sort of outside the box a little bit, but I'm really sort of excited about it. We know that there's a communication of nerves throughout the head, right? And so there was a very smart guy who came up with a design concept that said if you stimulate certain nerves, you can get a reflex tearing. You can get tears to start. And by stimulating these nerves, there's regular tearing, so the normal sort of tear production, and there's reflex tearing. Most people find that reflex tearing is sort of a flood of tears, but they're not really high quality tears, right? So if you cry all the time, you can still have dry eye disease. But with this pathway, what they found was by stimulating the trigeminal nerve, you can get a tear that's actually well balanced. And it has a lipid layer, aqueous layer, and mucin layer, and it's non-invasive. There's no medication, but it does require a little bit of a learning curve. And so what it is this little handheld unit, and you basically put it in your nose. And then you press the button, and it stimulates those nerves, and then you end up with this reflex tearing. So we'll see how it all works out. It's called TrueTear, and it's a nasal stimulation device for dry eye disease. And we should be having it here hopefully in the next few months to be able to help all of you with dry eye disease. At least try it, see how it goes. And when we look at dry eye disease, the pipeline's robust. This is a partial list, but there's at least 12 compounds on here that companies are looking at to help patients with dry eye disease. And so there's all kinds of different mechanisms of medications and different phases of trials, but really, really exciting for me as a practitioner, and obviously for you guys as patients, that we're trying to make our treatments better. We know that there's room for improvement, and we're working towards that. So I'm going to give you a couple examples. Of patients that we've seen. This is a patient who came in for surgery, who needed cataract surgery. And when I saw this, it looks like something called keratoconus. And keratoconus is a condition where the cornea can be weak, and that has implications for surgical planning and whatnot. But what I also noticed was that these rings here were not really complete. There's some missing up here, and it's not a very clean test. So we treated the dryness, and about 6 weeks later, you could see a much better thing here, and then this a much more normal topography. So this was just regular astigmatism that then could be treated with a toric lens at the time of cataract surgery. But if not, this patient, if we would have gone here, we probably would have had an error in their IOL power, which then would have led them to needing glasses or maybe further surgery to fix that. Another slide to sort of demonstrate the importance of the tear film in just a refraction and just getting a pair of glasses. If you have a tear that's not healthy, you end up with this ghosting that goes on, and if you treat the dryness, that can go away. So it's really important to even just for glasses to make sure that your corneal surface is healthy, because that can then affect your glass. And we all know that glasses aren't cheap, and so we want to make sure that we're as accurate as possible with our prescriptions. So last slide, I think. We have a paradigm shift in our management. So we talked about the traditional approach, but now we look at inflammation and MGD in all of our patients. We try to initiate testing early, regardless of their symptoms. Initiate appropriate treatment early and emphasize that it's a chronic disease. Treat the underlying inflammation and the aqueous deficiency and evaporative dry eye disease. And really, I'm a believer of being consistent and persistent. So if you're one of my patients, you've heard me say that you want to be proactive with this disease. You don't want to wait for it to get out of control before you try to get a handle on it. Oftentimes, I get patients that are already out of control, and then you sort of have to get them to improve before or they get worse before they improve, and it can be a challenge, but it's certainly manageable if treated appropriately. And so with that, I'll take any questions, and thank you for your attention. It's like, what comes first, the chicken or the egg? We don't know. I mean, I think they're concomitant. I think certainly blepharitis can play a big role in dry eye disease, but I couldn't tell you which one comes first. Yeah, it's huge. It's one of the biggest factors that play a role here, because what happens?
Which one contributes the most to?
It's individual again. Some people. What happens with most people when they pay attention is their blink rate goes down. So if you're watching TV or you're reading and you're interested in it, your blink rate will go down. If you're not, you may be blinking all the time. Certainly, airlines play a big role in that. We live in the desert. I get patients who go to Hawaii for a week for vacation. They say, I didn't have to use my drops at all, and then they come back here. The other patients that I see that a lot in are patients who are transplants to Southern California. They used to live in Florida, and then they moved out here, and they say, I never had dry eyes, and then after about 6 months here, I started noticing it. And so certainly the environment plays a big role in that. Yeah, so I haven't used a lot of Avenova, partially because it is quite expensive. It's hypochlorous acid, really dilute hypochlorous acid. People who use it, practitioners who use it, tend to find it to be quite useful for their patients. But I think, again, it depends on how you manage. There's no right way to manage dry eye disease, and everyone has sort of their own nuance to that. But there are a lot of believers in it. I don't know if we're ever going to get to the point that we'll say, hey, there's one drop you can use and you'll take care of it. I think it's too varied a mechanism. I think I'm hopeful that if we sort of, there's more and more sort of direct to consumer education on this. And so if we can catch people younger and get them to do certain things younger, then maybe we'll prevent some of the later stage complications of dry eye disease. But oftentimes patients in your demographic, it's been ignored for decades. And you might have had symptoms for decades, but no one ever thought about doing warm compresses. No one ever thought about doing omega-3s. And now we're playing catch up. It's a really hard disease to catch up with. It's sort of like diabetes. If your diabetes gets out of control, it becomes really hard to get it under full control. The reason that's been said is because in the clinical trial, patients were not allowed to use punctal plugs for Restasis. Therefore, by FDA rules, it doesn't work. Whereas this is one of those off-label things. So their thought is if it wasn't tested, we can't say that it works in those patients. So then Allergan has to say specifically that it hasn't been tested in those patients. Whereas we know as practitioners that we have patients on Restasis and plugs concomitantly all the time. Yeah. So yeah, OcuSoft is a company that has multiple products, right. And so this is like anything else. There's always going to be competition for these things, and if this works for you, great. I can't put a blanket statement that this is the way to go.
What we talked about was 0.01%. This is 0.02%. So
Right.
anyway, that's just,
So it must be twice as effective.
Now, with that said, I have another question though.
Yes, sir.
This has to do with reusing the vials and.
No one has ever done that before. No, I'm joking. Yes. So, yeah. Right. So the reason not to do that is sterility. Okay. That being said, no one can tell you what to do with your drop when you go home. And so there's a lot of patients who use the Restasis and they use the vial more than once. By the book, you're not supposed to do that just because of sterility issues.
But the quantity that they give you in those vials is obvious, it's so much.
Yeah. That actually has to do with keeping the Restasis stable. It requires a certain volume of the whole thing to keep the molecule stable. It depends on how bad your dry eye is. And when I went over the artificial tears, there's multiple different formulations of artificial tears, and they're all a little bit different. They all have different components in them, and so you have to find the one that works best for you and that gives your eye the relief, and then that then translates into improvement of the signs of your dry eye disease. Let me see if I can find this here. There's all kinds of different formulations when it comes to dry. There's the lipid containing, there's the carboxy methylcellulose, there's something called hydroxy propyl methylcellulose, HMC. Then there's the HP guar ones, which is another one, and then there's they all have a little bit different formulation, and so those everyone reacts a little bit differently to each one. But I still would recommend the preservative-free one over the preserved. I'm a more of a proponent of artificial teardrops versus saline drops. Saline drops, aren't really formulated for recurrent dropping in the eye. They're meant more for like contact lenses and whatnot. So if you do have discomfort, again, back to my proactive rather than reactive, if you do tears on a regular basis and then use more tears sort of for breakthrough, I think that makes more sense to me. But the preservative-free tears can generally be used quite safely multiple times a day. So rosacea, has accompanying skin signs that we see. It has some vascularity signs that we see. Allergy tends to have signs in your conjunctiva that we can see. Allergy has predominantly the major symptom is itching, whereas rosacea is not. So there are signs that we see that can sort of help determine that. So Muro 128 is actually a hypertonic saline. So that's meant to actually decrease corneal swelling or make the corneal cells stick a little bit more. So I'm not a big fan of that for dry eye disease. I know some practitioners recommend that. To me, it makes no sense. So what I would do is use it for the Fuchs and then use artificial tears in between. When you use some people think that when you use the artificial tears in between, that will make the flukes worse. That's not true. They don't go into the eye and make the cornea all swollen. It's not for run-of-the-mill dry eye. It's meant for quite advanced dry eye. I don't give that to patients who come in who just have dry eyes, who haven't really exhausted all other treatments, because generally it's not covered by insurance, and it's a recurring type cost. So I should be drinking a lot more water then, because it's there is some sense to being well hydrated overall. Do I think that if you're chronically, if you're always well hydrated, that'll take care of your dry eyes? No, but certainly if you are dehydrated, it can make you feel more symptomatic. So there is some value to that, but I don't think it's if you drink 8 glasses of water a day, you're not going to have dry eye disease. I don't think it correlates. All right, all. Well, thank you so much for coming. Appreciate it.